completed an end block on a nice lady from Indiana. She is 65 years of age. She has had implants from 1984, so that is a really long time. 1984. This is her one and only set. She said saline. Interestingly, the MRI was done, and the MRI radiologist who read it was not able to tell if this was indeed saline or silicone, which is very interesting because they should be able to conclude. But the patient said these are what are saline implants. So as you will see, grade 4 contracture. I removed some of the excess skin. It really helps, even the small amount. And as you can see, look as this. Now she fell off a bike, an electric bike, earlier on in the year. So she had bruising. The MRI did pick up on it, but this is the end block. So what I'm going to do is, it's a little bit, soft over here, as you can see as I press, but the rest of the area is hard, and we'll see this shortly. So as I go in very hard, I'm going to go in from this side. We did a case exactly like this last Wednesday. We did a Facebook Live, so you can only imagine how many patients are living with calcified, hard shells. So here we go. Remember, everything is preserved. If there's fluid, water, like saline, or anything that has ruptured, it's all contained. So let's go ahead and cut this open. You can actually hear, look at the internal contents, all preserved, none of this spilled. Remember, some surgeons are very keen about putting a needle in and then draining that saline. This is a horrible idea, absolutely contraindicated, not smart at all. This was a very difficult surgery. Blood loss was minimal, a lot of inflammation, as you can imagine. Look at this, we've seen this many times before. Look how hard this is. Hard like a rock. Now look at all this paste. This is like white paint, right? So look at this. We're gonna see more of this as I cut open. Let me put my finger in. 1984. This is Ronald Reagan era. I'm gonna go ahead and go in from here. Look at this paste. It's liquidy. None of this spilled into the chest. Remember, that's the beauty of the end block. None of this spilled into the chest. If you can imagine, if this spilled, it would be impossible to clean. No drain is going to drain this. Look at this creamish discharge. Very, very... Look at this. We've seen this many times before. So if I go like this, it's like white paint, literally. And this is dried up. None of this spilled into the chest. What I'm going to do next is, let me clean this up. Interestingly, this is what is a saline implant. I cannot make the, I cannot see the make or the model. So, saline implant. Alright, I'm going to go ahead and put this here, the right side. Now look at the inside. If I invert this, you're going to hear the cracks. Look at this. This is all, it's like dried up sand, if you will, mud. Lots of it, even more also over here. And super nice lady. She was very much hurting from what is this grade 4 contracture. And look at all this. So we'll see what the pathologist says. Look at how much there is. If you can imagine, as I was dissecting, if there was just a break and some of this spilled into the chest, this would be a big problem. And look how hard this is. If I go ahead and take my instrument. Now don't tell me saline implants are safe. In 1992, they should have banned these implants too. They cause the same set of problems that silicone implants do. And it is not right for any person to suffer. Look at this, you got some more of this. How hard is this shell? Right, and so again, and look, I can break this apart. Look at this powder. So we'll see the pathologist, and he's going to weigh in. I'm going to go ahead and change my gloves. Look at this. Very interesting. I'm going to change my gloves. Now the left one is even more rock solid. It's like petrified cement, like wood, petrified wood. It's like cement. I'm going to put this here. So gold standard en bloc, no spillage of the internal contents to the outside. No one knows what's on the inside. Not even the MRI. They did state there was some fluid around. You can see the minimal fluid. This is not enough to send to the cytology lab for BIALCL, but the pathologist will be certainly. So new gloves, we'll see. Now look at this. This is so hard. If I hold this, done en bloc. Look at this, you can actually hear it. Let me actually get this instrument. It's hard like a rock. And so I'm going to go in from here. I'm trying to literally crack the egg, if you will. So I have to have a nice access point. Very inflamed. So I'm going to go in from here. See, this is so hard for me to even grab. No one should live like this. All hard. Cement type consistency. So as you can see, if I dissect this tissue, this is all inflamed, and I just want to show, leaving this tissue behind. Let me just dissect this off. This is bad tissue right here. This is, remember, look at this inflammation. This is actually part of some of that muscle that had to go because of the severe inflammation. A lot of tissue. Very hard. Abnormal. So I just want to emphasize, all of this tissue is bad. And I just want to skeletonize this so you can see. If you send this tissue off, you'll see all the abnormalities of what is in the periphery of a inflamed capsule. So it is very important to remove all of this. I'm just going to go ahead and show you. This is the shell. Look at the color of it. So very important to remove this tissue. As you can see, this is not healthy tissue. This is all angry, inflamed, and irritated. So what I'm going to do is, actually see this bulge? This is like hard again. I'm going to go in from here. Good, we got lucky there. Again, you see the same thing. What I'm looking for is, I'm thinking there might be some fluid, so I have to be on the lookout for that. But overall, you see the same consistency. Look at this. Right? If I go ahead and take this, I can smear this against, break it apart. And this is grade 4 contracture on the left side as well, an intact implant. I'm literally going to tear this apart. So you can see, look. See how thin this is? You don't want to tear into this and say, oh, this was too thin. I couldn't remove it. Look at this layer. Then I'm going to chip away. And then look how thin this is. And look, this was the layer. You can see how frothy and air bubbles are present on the inside. How abnormal this looks. You don't want to leave this behind. All inflamed tissues removed. Remember, that is the key. You can see how thick that is. I'm actually going to go in from here. Alright, let me use my fingers now. I can literally tear this easily. This is the, look at this. We'll see what the pathologist, remember, no one can tell what it is and what it is not. Only the pathologist can look at it with the right stains and then conclude. What's very impressive is these are implants from '84 Saline. and they did not rupture. So I'm going to go ahead and pull this out gently from the shell. It's like a turtle, in the shell of a turtle, if you will. Now I want you to hear this, guys. Okay, you can see, look, here's the shell, and literally I'm going to, you can see the ruler. See the ruler? You can see number 5 written there. That's how thin that capsule is. Now if there was some fluid, we don't want it to spill, and so the surgery has to be done very carefully. I literally can put water in this, it's not going to leak because this is the end block. Remember, they won't break. Now hear this. Some of it made it to the ground, but you can see. Look at this. Saline implants, dangerous as much as the silicone implants. So there you have it. End block, the gold standard, no other better way. This nice lady, she's not gonna, this is the con procedure. She's not gonna get drained. She's not gonna get a lift. And she'll do relatively well. We'll see how she does. She had a grade 4 contracture. I will tell you that's a contraindication into moving around or doing any of this lift operation. Fat grafting, I would call malpractice. You get dead fat, and that causes fat necrosis, and then now the patient's feeling hard masses. When she gets her next mammogram, it's going to throw her off. So going back to the con procedure, number 1, no drains, no lift, twilight sedation, the capsule center pathology, rule out the BIA, LCL, CD30 analysis, rule out lymphoma, rule out malignancy, rule out any abnormal pathology, cultures for aerobic, anaerobic, and fungal, pictures done that basically show complete removal of the whole capsule, and certainly indeed cutting open off the whole capsule in the fashion that we did. And then if there is any abnormal fluid, that fluid is indeed what is sent to cytology. In this case, there was no fluid. And then the same surgery is done on a 76-year-old, for example, that I saw yesterday, or the 25-year-old. She is going to get the same surgery without any compromise, and a complete comprehensive workup is done without any doubt, leaving any capsule behind. The whole gist and purpose and essence of explant surgery is to remove the whole capsule completely, sincerely, so none of this spills into the chest, and that post-op the patient has the peace of mind and that freedom that all of this capsule was removed. And what ensures it, if your surgeon does 2 things. Number 1, that the surgeon does not put in implants. That authenticates, certifies, and solidifies with confidence that your surgeon is going to remove the complete capsule plus all inflamed tissue and get it tested. And the second thing is, your surgeon must be very transparent into discussing as to what is the goal of the surgery, and should be very nicely prescribed on a consent form, and that there should be a check and balance, a reputation that the surgeon has in the community, so that the appropriate surgery is done, and post-op the patient has the best chance to bounce back, and the freedom and confirmation that there is no toxicity, there is no fungus, or there is no cancer, be it squamous cell or BIALCL or anything like that. So there you have it. This is Dr. Khan, Executive Plastic Surgery.